Terrific. Welcome, everyone. We're so excited for today's webinar on the impacts of hypotonia on overall development. And we see people are streaming in. Thank you for telling us where you're joining from. It's really exciting to see we're really from all over the world together here. And I think that speaks to the importance of today's topic, that this is something that is really a universal challenge. And so we're really excited to kind of start to tackle this topic today. So for anybody who doesn't know me, my name is Gabi Conacher. I am co-founder of Deep Connections and the International SCN8A Alliance. And I'm so thrilled today that we are starting this 6-part series with our friends at the CACNA1A Foundation, who brought this really important topic to us to share with the wider DEE community. A quick little bit of housekeeping is that our session is being recorded. Participants are not on camera, but please do make use of the chat function if you have thoughts that come up during the webinar. And specifically, if you have questions, try to use the Q&A feature. We will be monitoring that throughout, and really will focus on getting questions at the end, though, because Theresa's got a really jam-packed schedule for us today. So we're going to really try to move through quick and then save a chunk of time at the end to dig in. For your questions, though, be sure to ask more generalized questions. You know, as a service provider, Theresa cannot give you advice about your child in particular. So as much as possible, try to put those questions in the chat with a little bit more kind of a big picture idea. So I'm going to go ahead and hand it over to Sunitha, who is the Vice President of the CACNA1A Foundation, to introduce our guest expert speaker for today. So Sunitha, on to you.
Thank you, Gabi. Like Gabi said, we're so grateful to have Theresa Spong here with us today. I'm going to only briefly introduce her bio because she has a lot of a quite extensive amount of experience, and we have a lot to cover today. So Theresa has been practicing as a physical therapist since 1984. She holds a bachelor's in physical therapy from Texas Women's University, and she specializes in the field of pediatrics in early childhood intervention and in the school arenas, as well as in private outpatient pediatric physical therapy. She has over 35 years of experience as a physical therapist working in acute care settings as well as pediatric settings. She also holds a master's degree in early childhood special education from the University of Texas in Austin, and has been an instructor at the University of Texas, specializing in training for teachers working with children with disabilities. Even more special for us today at the CACNA1A Foundation is that Theresa is a grandmother to a beautiful baby girl with a CACNA1A variant, so she's intimately familiar with our community. As you'll hear in her presentation today, she has quite a lot of passion for this work and her patients, and so we're so excited to welcome her as part of this entire series. So thank you, Theresa, for being with us today.
Thank you, Sunitha. I'm going to go ahead and share my screen here and bring up my presentation. And we're going to start slideshow. Okay, so thank you all for joining us today. I really appreciate you taking time out of your busy schedules. And I'm going to tell you a little bit about our story. This is my family. We live in Texas. So as you can see, this is my husband, my son, his beautiful dog, Callie, my gorgeous daughter, Brittany, her husband, Tom. And of course, the reason that I'm here today is because of Louise. So who knew when I started in 1984 working in pediatrics and working with kids throughout my career that this would intimately affect me in a much more special way. So this is Louise. And you are going to get to see a lot of her today as we tell stories, and I use case studies of kids because we are not in person, so I like to teach using a lot of video and footage so we can really see what's going on. I want to talk a little bit about the series of webinars so that you don't kind of think, oh, we're going to get to cover everything today. As Lisa and Sunitha and I were talking in the initial beginning, and we were talking about ideas for these series of webinars. We really started to figure out that we really needed to break them up into smaller bites. I think obviously I can teach an entire graduate course on special needs kids, and we don't have that kind of time. But I wanted to talk about the first 6 that we've sort of put together for you already. The first 3 I'm going to teach for you and be your host. The first one today, we're going to talk about hypotonia, and it's going to continue on as we start talking about ataxia, hypertonicity, and the fact that really a lot of kids have mixed tone issues, especially in the more neurological sides of the developmental world, right? And we're going to talk about therapies and some things we can do. We may not get to everything today. So be patient, it will be coming. Our third one, I'm really going to dive more into adaptive equipment and how you work with children who kind of don't follow a developmentally like the path of I'm going to sit, crawl, walk, right? Like doing some things a little bit differently, and so needing adaptive equipment. And along the way, we're going to talk about funding and how you get those things done. A good friend of mine is going to teach the next 2 classes. She's an amazing speech language pathologist, and she's going to talk mostly about children who are nonverbal or who have minimal verbal skills. And she's going to talk about low tech, no tech solutions, and then some high tech solutions. So she has decades of experience as well in this field. She's one of the finest speech language pathologists I've ever worked with. Our 6th in our series is also a friend of mine, Michelle Gable, and she has an extensive background in working with kids with all kinds of visual impairments. And she's going to talk about cortical visual impairments. And of course, the idea was we wanted to start with the basics. And then as you guys join in, you may have some ideas of other topics in this sort of therapy webinar series that you would like to see. And we are definitely open to your suggestions and ideas. If you want to share those with Gabby or Lisa and Sunitha at the CACNA1A Foundation, we're happy to look at putting things together. The idea is that there's going to be 1 a month, so you have time to sort of digest things along the way. But today, we're going to talk about hypotonia, and we're going to talk about how it impacts everyday life, because I think it is the very foundation. It's at the very heart of all the rare X genetic disorders. Many of the kids in the DEE group have seizures and complex medical problems, but I would bet every one of them has some level of hypotonia. And so I think we have to first understand how that impacts development. So today, I'm going to define and clarify hypotonia for you, because there's a lot of different ideas out there. And I want us to have the same idea about what we're talking about. We're going to look at how it impacts our health and wellness for our children or ourselves, because some of you on the call may be adults, right, that have hypotonia. So it's not just children, it is how it affects us in our entire lifetime. And we're going to look at some general ideas of strategies, simple things you can do in your home that don't cost a lot of money, that are just about practicing and what is it that we're looking at. I want to again emphasize that I can't really make recommendations for specific children. And remember, anything that you see today, you should probably run by your own personal therapist, because I'm betting all of you have a therapy team or a medical team that you work with in your area. So definitely, make sure that these activities are appropriate for your child. So we can't talk about hypotonicity without first defining what is muscle tone. So muscle tone is defined as the degree of muscle tension or resistance during rest or in response to stretching. So it's a state of tension that is maintained continuously in all muscle tissue, right? So I'm sitting here today, I'm sitting upright, and if 10 therapists looked at me, they would probably say I fall within the range of normal muscle tone. Right? So what is hypotonia? Hypotonia is poor or low muscle tone. It's in a lack of resistance to passive movement. And I put some handouts in the materials that explain this, I think, in a really great way. So I'm going to let y'all read through those if you want more information about it. But I want to explain just a couple of things. Tone and strength are not the same thing. That is often a misunderstanding. Like they just think, oh, if I strengthen and strengthen and strengthen and strengthen, right, I'll get stronger. Tone is more about a muscle's potential to move. So if I'm a person who has normal muscle tone and I go to a gym and I work out, right, and I lift weights, I'm going to get stronger and stronger and stronger and stronger. And I may get more toned and my body may look a little more trim and slim, right? If I have low muscle tone, depending on the degree of low muscle tone that I have, right, I may get a little bit stronger, like I may be able to lift a little more weights, but I'm only probably going to get to a certain point and then I've reached my potential. So I like to think about kids in terms of their potential. I think all kids have potential for change. And as we look and we move forward, we want to keep pushing them to make changes, to improve their endurance, improve their ability to do things. But it's all about that potential. And tone, most importantly, is the foundation of all movement. So we have to first, when we're building a house, we have to build our foundation. And if we don't have a good foundation, our walls and our roof are going to fall apart. So it's really important that we lay this foundation as strongly as possible. So I wanted to bring up some concepts that we're going to just talk about all throughout the next hour. Children with hypotonia have difficulty initiating muscle contractions, right? So they often have a delay in a response to what we're asking them to do. Their muscles contract slowly, and they may not be able to maintain a contraction for a long period of time. So their ability, their endurance is strongly affected, right? Because maybe they can get up for a few seconds, but then they fall. And they can get up for a few seconds and then they fall. But sustaining contractions and postural muscles for these kids is where they really have a hard time. And in our third webinar together, we're going to talk about those kids who have difficulty maintaining postural control and what we can do externally to help support that so that they can function to the best of their ability in their environment. So we're really going to tell the tale of two children today as we go through here. We're going to talk about Louise, and she definitely falls more within the milder hypotonicity spectrum of things. And we're going to talk about Jaden. And Jaden definitely falls more in the severe end of the spectrum of low muscle tone. So we're going to kind of talk about the things that they have in common and the ways they move and where they fall apart. So I'm going to tell you a little bit about each one of them so you kind of have a baseline of knowledge here. Louise was a pretty typically developing baby until about 6 months of age. And then we began to notice her PTU, her hypotonia. She began having vomiting episodes. Her weight gain got a little funky up and down with vomiting. We started seeing neurologists and geneticists and all the ologists, right? And in August of this year, we got her diagnosis right around her first birthday that she did indeed have CACNA1A. So interesting set of circumstances how we got an early diagnosis, but persistence, right? And getting to the right doctors and the right people. Jaden is definitely one of those kids who I think defines low muscle tone. And I really wanted to pick a kid for us to see today that didn't have mixed tone issues so that you could really see what low tone looked like. So I want you to notice Jaden has an undiagnosed genetic disorder. My guess is he is going to fall well within those rare X genetic disorders. He has been genetically tested 3 times and they cannot seem to find anything that it just glares out at them and says, this is what this is. When I met Jaden, he was 15 months old. He had been with another early intervention program and did not have a great set of therapists working with him at the time. And so he came to meet me. At the time I met him, he had 16 doctors that he saw on a regular basis. So pretty much every organ system in his body, he's got a doctor he sees, which I'm sure is the story for many of you out there in our audience. What I want to point out in terms of low tone for him is you notice that when he lays on his back, even though he is not quite 3 years old, he is a little over 2.5, he'll be 3 in June. He still lays mostly looking to one side, right? He has a difficult time getting into midline. He has ATNR reflex still that you see where he kind of puts his arm straight, and that's a therapy thing, right? He has very wide base of support in his hips, so his hips turn out and they're externally rotated, which is a very common thing that we see in kids with low tone. And then if he tried to sit, he looks like a fold-over sandwich, right? He just folds over and everybody goes, oh my gosh, doesn't that hurt? It actually doesn't hurt him at all. He is super flexible. So we're going to talk about some of those things that we were seeing as we go through development. We're going to talk about how they cheat in how they move and how that changes how they develop. So I think it's really important that we understand how typical development occurs so that we can understand where do our kids with hypotonia start to lose ground and lose skills. These are just 3 very important concepts that I want to mention. Babies develop head to toe. That's an absolute rule, right? We don't develop from our feet to our head. We develop from head to toe. And the way we develop from head to toe is our head starts to come up, right? And our eyes start to engage. And as our head starts to come up, we also have this flexion on this side starting to develop at the same time. So we have extension followed by flexion. And it develops all the way down the neck, the spine, until we get to sitting, right? So our kids don't do that so great, right? They don't get up against gravity. They don't really develop head to toe. And most people don't think to put their babies on a therapy ball. So I want to show you Louise. This is Louise when she is 4 days old. Not because we thought she had CACNA1A at this point, but because her Gigi is a physical therapist and she knows how important it is to put babies on their tummy from the moment they're home, from the moment they're born. And she has a yoga ball, and she's been on that yoga ball since she was home from the hospital. The second most important rule is babies develop from proximal, which is our midline, right? So our core, our shoulders, our hips, to distal. So distal is out here. That's our hands, that's our teeth, that's our tongue, that's our feet, right? If we don't have proximal control, we won't have distal function. That's just the way it works, right? The next thing that we're going to explain in a lot more detail as we travel through development is babies first develop mobility, then they develop stability, and then we get mobility superimposed on stability. And those are just 3 very basic rules that we're going to talk about as we move through development. So, what is the difference from the very beginning? Your baby is born and they have low muscle tone from the very beginning. So first of all, complicating things is often kids with rare genetic disorders are born prematurely. It's kind of a thing that I see in my years of practice. A lot of these babies are early, so again, we have prematurity and we have this low muscle tone because of a genetic disorder or seizures or complex neurological problems, right? So when babies are born, full-term babies are born, they're born with this physiological flexion. And that is because they're all nice and tight up in mommy's uterus, right? And they're tight and all tucked up. And so when they're born, they're actually born with a little bit of contractures in their joints. So if you try and straighten out their arm or pull their arm out, they kind of pop back a little bit. They have this physiological flexion. If you are born with low muscle tone, and if you are a premature baby, you are not born with that physiological flexion. You are born out here, right? So your body is more extended and it's not in this nice, tight, curled up little ball that we need. So that changes the way that I'm going to develop because I'm starting out here instead of in here. And remember, I said the first rule is we have to first develop mobility. So in a typically developing baby, they develop mobility by moving off of this nice contracted body that they have. So their range of movement is a little more limited and more controlled because they have that physiological flexion. If you don't have that and you have to just learn to move up against gravity, it's much more challenging. One of the things that I think we don't spend a lot of time talking about as therapists and as doctors is that when you have low muscle tone, you also generally have loose ligaments. And so why is that important? When you are born, you don't have muscle control of anything, right? So you're basically a skeleton, so your bones, and your skeleton is held together with ligaments, and those are little pieces of fascia that go from bone to bone. And then you've got muscles, and those are tendons and ligaments, right? Tendons that attach at different points in your body, right? And your skin. And that's what holds your body together. So if I have low tone, my muscles don't work real great, and I'm a baby, and I don't move real well. And then I also have these ligaments that are really stretchy and hypermobile, right? They're not nice and tight like they should be. Then my joints are very loosey-goosey. And the reason I bring this up is you can't strengthen ligaments, right? Like they're fascia. There's nothing you can do unless you surgically go in and tighten them all. And most of us are probably familiar with ligaments like in the knee, because if we watch sports at all or whatever, we hear people say, oh, I tore my ACL, right? My anterior cruciate ligament in my knee. So people do tear their ligaments and people kind of are aware of them, but most people are not aware of how important they are in learning to move up against gravity. So if my ligaments are really wobbly and my muscles are really weak, then I even have more of a challenge getting up against gravity. And most of our kids have poor core. They have poor stability. So remember, I said you have to get mobility, then you have to get stability, right? And so stability is being able to stay in a place and hold myself up, right? So these are definite challenges for our population of kids. So we're going to kind of move through development here. And this is one of my favorite topics. I love to teach development. And we're going to do this with a series of videos and pictures. And of course, I'm going to have to jump through it pretty quickly. But I want to talk about prone because being on your tummy is one of the hardest things for low tone kids. So this is Jaden. He's on his tummy, and you see poor baby. He just has such a hard time. He can't get his head up. You'll notice that if you can kind of see in his shoulders here how his scapulas are winging, right? So he doesn't have nice stability in these shoulder girdle muscles. You'll notice again this wide base of support that he puts his pelvis in so that he can kind of gain some stability from the floor. So I took these pictures just like a month ago. So this is him in the current, right? He actually can lift his head, and I'll show you some videos of him doing some things later. But it's very challenging for our babies to get up against gravity and hold their head up. And so what often happens, because they're on their back a lot, and because containers that we have created in our world mostly keep babies laying on their back these days instead of on their tummy, these babies can develop secondary problems like torticollis and plagiocephaly. So when I met Jaden at 15 months of age, he did in fact already have a helmet and a torticollis because he had been laying in one position for a long period of time. And a torticollis is a tightening of the neck because we always kind of keep our head one way. And because his skull was soft and his bones were soft, he was always weight bearing on one side of his head. And so he created sort of an asymmetrical skull shape. So I'm sure a lot of you have seen the the helmets that go on kids, and they try and reshape their heads. So these are just some secondary issues that can come up, and another important reason why these babies need to be on their tummy. I really want to talk, I am not the vision expert, but I want to talk about how vision impacts these kids in a big way at this point in time. If you think about how babies learn, they learn 80 to 90% of what they learn through their visual field. So if they have complex things like cortical visual impairment or other visual things like nystagmus or PTU, right? Those also impact how they're able to visually learn. But if I only see things when I'm laying on my back or when I'm laying on my stomach and I'm not using my vision and I'm not getting up, I'm not triggering that visual system. And it's really important that babies start to get their head up and that they start to use their eyes if we want them to learn to use their vision. So propping and prone is really hard for them. So we're going to talk about, I'm going to show you some pictures. We're going to move on. We're going to talk about propping and prone, rolling over, sitting up. We're going to do this by looking at some pictures and videos. Okay, I need my little mouse here. All right, so this is Jaden, and I wanted to show you what he can do in sitting. So you'll notice he had his head up and then collapsed over. And so I'm just going to give him a little help. Try and see if he will push up with his little arms for me. And he is putting his hands down now. We're pretty excited about that. He really does adore me, but he does fuss at me a lot when I make him work. So I wanted you to kind of see what he looked like just on the floor if we were just hanging out. Because we're going to talk about rolling, I wanted you to see how he rolls. And I really want you to notice what an effort this is for him. Notice his rib cage and his breathing. Notice how he's got to kind of push really hard. And notice how he's breathing. See how much effort that is for him. So we're going to look at that again. So because he's so flexible, he can tuck that right shoulder under him, right? He's not really actively having to engage the shoulder, and he's really just trying to push with that left arm and get over. And you notice he uses his whole hips and legs to get him the rest of the way over. He can, in fact, roll, and he rolls to get his toys. That's one of the things we have him do. This took us a good 6 months to get him rolling when I started with him. At 15 months of age, he wasn't rolling, couldn't hold his head up, wasn't doing a lot of moving at all other than some random hand and feet movement. He has lots of cool toys. He loves this sloth. You're going to get to see this sloth quite a bit in his videos because that is his favorite toy and the one he will move for the very most. But I wanted to just point out how much effort that is for him. So one of the things all of my kids have in common is they all have a yoga ball. So not just Louise, who started when she was 4 days old, but all of the kids I work with. It's really important. I think this is the cheapest, best therapy tool you will ever buy in your life. It is $12 on Amazon or $15 depending on what brand you buy. You can buy them at Walmart. You can buy them anywhere. They're readily accessible, and no matter what your house looks like, a yoga ball is a good idea. So I wanted to show you how much better he looks on a ball. So we really started with him on a yoga ball, and we really did a lot of work. He spends as much time as I can possibly talk his family into doing on this ball. So I want you to notice him on his tummy. He's got his head up. I'm keeping his elbows under his shoulders. Now you notice the farther I bring him forward, the more difficult time he has with this task, right? So I want you to look at it again. So when we're back closer to me, he's able to hold his head up easier. As we move forward and gravity beats down on his head this way, he starts to lose that control. So when we're working, we work a lot where he can be successful. So we spend a lot of time with him tilted back closer to me. Keep those elbows under the shoulders. and keep him working. We spend a lot of time doing tummy time with him because this is where we're really building our head control. Remember, babies develop from head to toe, right? I've got to have head control if I'm going to have trunk control and if I'm ever going to hope for him to crawl or walk in the future. So we have to gain that head control. I want to show you how much better he sits on a therapy ball. So this is us a couple of weeks ago. I'm my own videographer, so pardon the video, but you'll notice we're working front to back, right? Front to back, and notice how he can keep his head up. And when he starts to lose his head control a little bit, he'll bring it back. And now we're going to go side to side, and you notice he's really starting to right those head and balance his head in this motion. He works on a therapy ball upside down. He works on a therapy ball sitting. He works on a therapy ball on his tummy. We work standing at the therapy ball. I love balls because they are so versatile. We can move in all planes of motion, and all that bouncing really jazzes up our muscle tone, and it works our vestibular system and proprioceptive system all at the same time. And we're going to talk about the importance of them as well. But I wanted you to really see that everything above my hands, he's having to control. Okay. So now let's look at Louise on a therapy ball. So Louise is a little bit younger, but it doesn't really matter your age. You can be 9, you can be 12, you can be 50, right? It doesn't matter how old you are. The same principles apply. So again, if we put Louise in motion here, she's sitting on a ball. You'll notice how rounded she is through her lower trunk here. I'm giving her some external support so that everything above my hands, she's having to work, right? And as she gets stronger, I move my hands lower and lower and lower. I'm giving her something to hold on to because that is really important if you have a child who can also hold a toy. Otherwise, they tend to cling on to you when you're playing on a therapy ball. But I want you to really notice she is actively engaged with me, like we are eye to eye, right? And we are working on her balance system, her inner ears. We're working on her visual system. We're working on her proprioceptive system. And at the same time, we're jazzing up her muscle tone. So she does a great job of really responding. And of course, at this point, she's not really sitting on the ball. So we're going to fast forward to 2 months ago in October. And we're going to see Louise on the same therapy ball and all the activities that she can do on it. Now you notice now her spine is nice and straight. McKenna's able to hold her down at her knees. She's not having to give her trunk support anymore. And she is able to go front and back and side to side. And you notice she even turned and looked at the TV and rotated a little bit in this position. I want to show you something again that I wanted to mention. When McKenna quits bouncing her, she tries to bounce herself, right? She loves to bounce on a ball. And one of her favorite activities when she sees Gigi is she'll go ball, ball, because she knows Gigi's going to put her on a ball. Now, Louise is, she's very lucky, right? We are very blessed. We have a tremendous village of people to support us. And so I wanted to talk a little bit about the importance of building a village for yourself and your child and your family. So McKenna is my niece. She's also a PT assistant, so I also try and train the next generation. But my sister and her came and stayed with Louise for 3 days in the fall so that my husband and I could go on vacation. We were Louise's babysitters for the first year and a half of her life. So she spent her days with us and her parents. And that's fortunate, because we could one-on-one work with her all of the time. And I know that's fatiguing, right? I know it's hard when you are a lone person or you don't have a family support system that can come in and provide supports for you. But I encourage you to find your village, whether that is with church groups or neighbors or friends Or if you live in a place where there are universities that have special ed teachers being trained, or nurses being trained, or PTs or OTs or speech therapists being trained, don't be afraid to contact those agencies and see if there are people that might be willing to volunteer, right? Because they're going to learn something, they're going to get something out of it, and they can also help support you doing therapy activities, because PT is not the only thing that's happening, right? Often our kids have PT, OT, speech, nutrition. We have a ton of doctor appointments to go to. There's a lot going on. So having a village is very, very important. And I talk to my families about that a lot, because I do recognize that Louise was very lucky. She probably spent an hour on a ball a day. And my daughter and my son-in-law are amazing, and they follow through with all of her activities. And together, we all work together, and Louise has benefited from that. Okay, let me see. So that's my soapbox about build your village. Okay. So in sitting, what's important about sitting, I'm going to just go back and revisit a little bit of this so that you really understand how important their core is to everything. If I am a baby and I have a skeleton, right? So I'm a skeleton, I have a spine, I have a rib cage, I have a pelvis. What connects my rib cage to my pelvis? It's muscles, right? It's all muscles. What allows my ribs to expand and contract? It's muscles. What holds my spine up? It's muscles, right? Everything is about this core right here. We have to have a stable base in order for our hands to work, our mouth to work, our feet to work, our legs to work. We have to have this stable base to work off of. And if we don't have that, then we start to see difficulty with the more distal. Remember, proximal to distal, right? So if this is weak, then we aren't going to have great function out here. So I really want to emphasize how important it is to build that core. My favorite way to do that is on a therapy ball, but we also, as you will see towards the end, use all kinds of tools to get that core really building strong. And it's really important, especially that we build these oblique muscles that come from the ribs to the pelvis, right? And so these kids are upside down on a ball, and we are doing tons and tons of sit-ups and really, really working their core from the very beginning. So now we're going to move on a little bit up through development. I'm going to take you up through some walking skills, and then we're going to talk about some health impacts. One of the reasons I want to emphasize the importance of belly scooting and crawling is because I think the majority of the world has skipped belly scooting and walking and crawling, and they just want to get to walking. And I think it's critical that kids belly scoot and they crawl if at all possible. Now, some kids may not ever get there, right? But this is how our vision develops, our eye-hand coordination develops. So if I'm belly scooting, right, and I'm moving arms and legs and eyes together, I'm starting to develop that eye-hand coordination. And what is that eye-hand coordination important for? It's important for reading. It's important for writing, right? All those upper level skills. So Louise did not want to necessarily belly scoot very well. So we would get behind her with our little hands, and we would make her push off our hands, and we'd push her forward and push her forward and push her forward until she could start to do some belly scooting on her own. Now, one of the things you may notice with her belly scooting in this tunnel, I love these tunnels, because one, it's fun, and the kids think it's fun to come and get a toy or a snack or whatever. But you notice she only pushes with her right leg. She doesn't use her left leg to push forward. So we would work with that, right? So these are some of the cheats that you'll start to see. Kids really will dominate one side, especially kids with hypotonia. They usually have a favorite side. One of the things that I see a lot with kids with hypotonia is they butt scoot. right? They want to scoot on their bottom instead of getting on their belly, because the belly is hard. Tummy is hard because I've got to hold my head up. I've got to use my shoulders and my pelvis. And so it's just so much easier if I learn to sit, I can scoot on my bottom. That's a bad habit that I really like to discourage in my kids, and I really do make them belly scoot. So once she learned to belly scoot, we made her belly scoot everywhere. If it was time to go have a snack, she had to belly scoot 50 feet into our kitchen to go get her snack. If it was time to go back to nap, we belly scooted back. I really had to talk to people about not carrying her because she's awfully cute, and it'd be so great to just pick her up and carry her everywhere. But the reality is, the more we make her work for herself, the better she's going to get at that skill. I want to show you what Jaden, this is Jaden as of a few weeks ago. He loves to get in this position, but he can't push himself up. He has a really hard time getting up against gravity. You notice again the effort and the breathing, and he really wants to. He really wants to get up and move. And when I help him, I tried to shoot some video of that. It didn't go so well, so I don't have any video footage of him pushing up onto hands and knees with my help. But he really tries very, very hard to get up and move against gravity. And he actually has a great deal of adaptive equipment. And in the third one, you're going to see Jaden very much again, how we have modified his environment to be able to function a bit better by bringing in some adaptive equipment for him. So again, the impacts of vision, eye-hand coordination, belly scooting, crawling, super important. Okay. Now, second most common cheat besides butt scooting, if you're hypotonic, is W sitting. And if y'all were all on screen and I asked you to raise your hands, and you could raise your hand and say, oh yeah, my child W sits, or this is a pattern that you see. I'm going to actually let you hear the sound this time of Louise, but I want you to notice a couple of things. She is 14 months old here. She still crawls with a very abducted posture with her knees, and you will notice that. Again, that's those loose ligaments, that hypotonia, right? Instead of having her knees right under her pelvis where they need to be, she still has this really wide base of support. But I want you to see, she started W sitting pretty early on when she was learning to sit, and we had to correct it a lot, and we still correct it. She still likes to W sit. So
what does a camel say?
see her wide base of support? This is W sitting, right?
Good job.
So I don't want you to think that it did not take months and months of telling her to fix her feet to be able to do that. Every time she would W sit, we would tap her feet and say, fix your feet, and we would fix them for her. Now we just have to verbally remind her to fix her feet, and she can do it. But it takes months and months of not letting them W sit, right? It is really important that we do not let babies W sit. And I'm going to go back and I'm going to play a little bit of this for
What
you.
does a camel say?
And we're going to stop it when she W sits so that I can point out some things about hips and knees. Okay. So it's called W sitting because they look like a W, right? You can see the W with their legs there. So the reason kids with hypotonia or even kids with hypertonia like to W sit is that it allows them to lock their pelvis between their legs, right? So it gives them external stability. So they don't actually have to use their own trunk muscles to sit. So it's a cheat. But it gets in the way of their movement patterns. So they can't rotate in and out of this position easily. So those rotational movements that we need for transition skills, like getting in and out of sitting, in and out of crawling, right, gets in the way of that. But more importantly, as a physical therapist, I just want to do the homage to, oh my God, what this does to your hips. So it creates tight hamstrings, because our hamstrings attach back here and behind our knee. And if we sit in this position, our hamstrings are in a short position. So it tends to create hamstring tightness. The second thing that's a big problem is tibial torsion. So tibia is that bone in the bottom of your leg that goes from your knee to your ankle. And you'll notice, because of the way they're rotated in, that tibia never straightens. So what you wind up with, if I unwound her and stood her up in this W, is that you would have a baby that walks with their feet like this, because they have a tibial torsion. And that's a bone problem. That's not a muscle problem, but it comes from sitting in a W all the time. And the very last thing, of course, that therapists really dislike is hip dislocations, right? We are very particular about our hips, and we want them to develop well. And when you W sit, you sit with your hip internally rotated in the hip socket instead of externally rotated in the hip socket. And so you develop a very shallow hip socket. And so this makes it much easier for babies and children to dislocate later in life. So one of the things I spend a lot of time doing, if people have stairs, I'm fond of stairs as a therapist. I think it's a great teaching tool. It's a wonderful way to correct crawling problems. It's a wonderful way to teach kids to start to pull to stand. So as they climb up the stairs, you'll notice like she pushes and crawls and pushes and crawls, right? And so this crawling position that she does, we just translate crawling into something functional. And why is it important? One thing it teaches is motor planning. It teaches eye-hand coordination. It teaches coordination of movement. Now, I'm sure you all noticed how much she turned out her right foot. So she's got a lot of pronation in her feet, and we're going to talk about that as children get up and stand. Kids with low tone tend to really pronate in their ankles. They collapse their arches in. And exercises like this can really help us with strengthening their muscles in their legs, their hips, their trunk, right? So this is a great activity to work on with kids. If you don't have stairs in your house, you can always use couch cushions and pull one cushion down so that you've got the floor to the cushion to the base of the couch, and the couch to the next cushion. So you can create your own stairs in your house. I do this all the time with my kids and families. I want to talk a lot right now about once we get to pulling to stand and standing, what are some of the cheats that we see with hypotonic kids? And again, it doesn't matter whether they're mild or more severely impacted, they tend to do the same cheats. So if you watch Louise pull to stand here, you'll notice she still pronates. She gets up on her ankles. She's trying to lock her ankles, and you'll notice her hips are pretty unsteady, right? So she's just kind of learning how to pull up and be able to hold on to furniture and get that coordinated movement of pulling up. I put Jaden here in his gait trainer so that y'all could get a really good idea what he looks like without any braces on, right? So you notice this collapsing of the foot and the turning out of the foot. You'll also notice that he tends to lock in his knees, and they also tend to stand on their tiptoes like Louise was doing earlier. So those are, again, some typical cheats that you see. So we do lots of practice. You cannot do enough practice, in my opinion. So once they can stand, then we start working on cruising. You'll notice she still pronates a lot in her ankles. You'll notice she's still a little bit wobbly in her hips. I tend to use times of the day that are naturally a part of their routine. So this is snack time for Louise. She spends her 20 or 30 minutes of snack time going round and round a table, right? When she was learning to crawl, we spent snack time crawling down the hall. So we use the natural routines of their day so that it becomes an integral part of their day. And they begin to get the idea that we move to go places, right? And that we can start to move on our own. Because if we carry kids everywhere they're not ever going to move on their own, and they don't start to get that idea. And the more we can embed their practice in their daily routines, then the less stress it is for you to carve out an hour a day to do their therapy with them, right? So if I spend 20 minutes twice a day at snack time, and that's when we're going to work on cruising, or that's when we're going to work on crawling, or that's when we're going to work on belly scooting, that's snack time. We get our snack accomplished, and we get the task that we're trying to accomplish accomplished. Also, then once they can cruise right around the furniture, I can't tell you how many laps she did around Minnie Mouse there. We look at things like push toys. So I also try and use things, if I can, and they're young enough and small enough, use things that other kids would use. Use the things in their natural environment. Now she's a little wobbly here. She's a little shaky. She's still really pronating in her little arches in her ankles, and her hips are not very steady. I just saw her this morning and she was doing that like a rock star. One of the things we wanted to do with Louise was give her the opportunity to go farther distances more independently. So I did get her a reverse walker with a pelvic stabilizer because she's a pretty unstable pelvis. And when you watch her walk with this, I want you to notice how she's still turning that left foot out. You will also notice she's got high top tennis shoes on here. And she's really just trying to figure out, how do I make this thing go? Now, I can't tell you how many miles she has walked in that walker. We took her out in the grass, out in the gravel. We made it harder for her because pushing against resistance is really hard. We walked up and down our street many, many days. I want to talk a little bit, though, about high tops SMOs versus AFOs. So she's wearing a high top shoe. That's about 40 bucks. This is an AFO, right? So ankle foot orthosis. And you'll notice that they look a lot like a cast. If I were going to cast a kid, right? That would be what it would look like. I don't like AFOs on hypotonic kids. If I've got a kid with a lot of spasticity, that's a different story. But if I can get away with not putting an AFO on a kid, I would prefer that. I am a very unusual physical therapist in that I'm not real fond of braces. I like to use things that are the least restrictive so that they have the best opportunity to move their own muscles the way that they need to learn to move. And so Jaden, when I met him, had a pair of AFOs that thankfully he had outgrown and did not fit him. And I got him a set of SMOs. So these are Sure Steps. They stand for supramalleolar orthotics. That's what SMO is. And you will notice one of the reasons I like these is their toes and their forefoot are free to learn to balance and move, right? How do we balance in standing? We balance because our toes and our forefoot really do a lot of work for us. It also has an opening in the back of the brace so that I can get plantar flexion, dorsiflexion. So I get a more normal step pattern. What this brace does is it keeps him from pronating. It keeps him from collapsing that arch in. So it holds his arch in place, but allows him to move the muscles that I want him to use in order to be able to walk. So I want to talk a little bit about avoiding containers. Low tone kids should really avoid things with slings. You'll notice this little baby over here to the very far right of your screen. This is what slings do to babies. They roll their hips out. They tend to be on their tiptoes. And they really don't learn to use their own trunk muscles if you're hanging in a sling. So I often see kids that have been in containers and they're on their tiptoes a lot. They don't have a good core. They don't have good trunk control. Their trunk is not connected to their pelvis. They're upright, but this isn't helping them learn to walk in any way, shape, or form. Why they named these things walkers, I don't know, because they don't help you learn to walk. As a matter of fact, they did a research study back in the 80s with identical twins. And they took one twin and put him in a baby walker a significant amount of time. And the other baby they left on the floor to develop. And the baby that was left on the floor walked 2 months earlier than the baby in the baby walker. So really, I'm going to encourage you to not use a lot of these particular things with slings, or minimize the time that they're in there. So let's talk about some sensory issues related to hypotonia. So we already talked about the fact that our kids can be a little bit under responsive, right? So they can have delayed pain responses. You may notice this like when they go to get their inoculations at the doctor, they get the shot and have the Band-Aid on before they cry. So they often have a high pain tolerance. These kids will fall a lot. And so they get a lot of Band-Aids, right? And boo-boos because they're just not real coordinated. They tend to be under responsive in lots of different aspects of their environment, not just their motor skills, but they can be slow to respond to verbal cues. They can be slow to respond to commands, things like that. We are going to talk about the vestibular system. This is your vestibular system. This is your ear. So these three beautiful purple semicircular canals inside your ear are your balance system in your planes of motion. So if I am really wanting to stimulate your vestibular system, I need to work with you on your tummy, in sitting, and upside down, right? I really need to develop all aspects of your balance system, which is one of the reasons I love therapy balls, is because I can work on your muscle tone, your core, your vestibular system, your proprioceptive system, your visual system, all at the same time. So I get a lot of bang for my buck. I want to talk about the proprioceptive system and how I think it is the most undervalued sense in our body, right? Everybody knows about the five senses, right? Touch, taste, smell, hearing, sight, right? But our proprioceptive system is really our sixth sense. And what it does is it gives us information about where we are in place in space. So it's this automatic feedback loop from our muscle tendons and our joints that's telling us where we are. So as we're sitting here today, I want everybody to close your eyes. And if I said, where are your hands? You could tell me, are your hands open or closed? You could tell me if your knees are bent or straight without even looking, right? Without even looking, you know where your body is in space. If your proprioceptive system does not work for you, if it's not engaged with your brain constantly, it makes it 10 times harder for us to learn to move. Because if I'm sitting here and my husband says to me, Theresa, come here, my proprioceptive system has already told my brain that I'm sitting in a chair, my feet are flat on the floor, and I'm ready to get up and take steps. If my proprioceptive system is not working, I could be laying on the floor, right? But my proprioceptive system isn't telling my brain where I am. So I don't know, how am I going to get up? How am I going to motor plan that? How am I going to get to where my husband is calling me to go to, right? So these sensory receptors in our body are super important. So what I did, because this is its own topic, and if this is a topic you would like more information on, give that feedback to Lisa and Gabby, because I just gave you a couple of handouts with lots of ideas of activities that you can work on that all help your proprioceptive system. So we're not going through those today in the interest of time, but it's pretty easy reading. They're handouts that I use all of the time. I want to talk about health impacts, like how does hypotonicity affect our health, right? So one of the first things, and we've already talked about it a little bit, is fatigue and endurance. So these kids fatigue fast. Their endurance is really limited, and every kid is unique. So Jaden, when I first started working with him, he could maybe go 7 or 8, sometimes 9 or 10 minutes with me, and I'd have to give him a break. And then we'd go again, and we'd go again. And I would be lucky if I could get 45 minutes of work out of him in an hour session, right? Now he can go pretty much the whole hour with one break. I usually do, and he tells me when he needs that break. He turns around, looks at me, and fusses at me, and I know exactly what he means. He is like, I need a break. Give him a couple of minutes break, and we're back at it again. So building their endurance is really, really important. That is a really important goal to address. And it's really not something therapists talk about sometimes in their notes. And if you're looking for those tiny little inch stones, as Gabby likes to say, those tiny little bits of progress, being able to do something 30 seconds longer or a minute longer is absolutely huge for these guys, especially our more severe kids. Constipation is probably the number one thing that I hear about from parents is, oh my God, my kid is constipated. Why is that? Well, think about it. If your muscles, your skeletal muscles have low tone, then why would the rest of your muscle system in your body be any different, right? So the smooth muscles of our small intestines, large intestines, that motility, right? That movement that moves food through, that aids in digestion, that allows us to poop. Those muscles are also probably weak. Louise has chronic constipation problems. We're always looking for ways besides Miralax to work with her. So I'm going to give you a couple of suggestions. Again, you should always check with your own doctor or nutritionist about whether these are appropriate. But infant massage is one of my favorite things in the world, and you don't have to be an infant to do infant massage. You can do it on a 9-year-old, a 12-year-old, a 15-year-old. You can do it on yourself. If you are a person with hypotonia, massaging your belly can really help to move things through. And so there are very specific strokes within infant massage that really aid in digestion. I gave y'all a recipe, and Gabby made it so cute. She turned it into a little recipe. I so appreciate that. And it is from one of my favorite nutritionists that I worked for 15 years. She gave this recipe out to all our oral feeders. It doesn't go so well through a feeding tube. So if you happen to have a baby that's tube fed, you may have to find a different way to do that. But I love using natural foods and things in your diet. So if you have access to a dietitian or a nutritionist as a part of your team of professionals that you see, I encourage you to talk to them about things that might work. But this particular recipe has been very successful, and we love it. The third thing that really helps aid in constipation and digestion is movement. So, after Thanksgiving dinner and you're all full and you've eaten way too much food, if you lay down on the couch, how terrible you feel. But if you go for a walk, you feel a lot better, right? So movement, it's really important that kids move. Therapy ball is a wonderful way. If your baby's constipated, put them on a ball. We used to lovingly call the therapy ball the poop ball, because I would walk into someone's therapy session and they say, oh, they haven't pooped in 3 days. And I'm like, okay, no problem. We're going to work on that. And by the end of the therapy session, or by the end of the morning or afternoon when we worked, generally they had had a bowel movement. So keep your babies moving and active, and that can really help with their constipation issues. And I do recognize there are kids that do have to take Miralax on a regular basis, and that's just a part of their treatment needs. If our cardiac system is also a muscle, then probably, right, there are some issues around heart. And many of our kids with complex medical needs also have heart problems. Jaden sees a cardiologist and has echocardiograms on a regular basis. So many of our kids with complex genetic disorders have multiple organ systems that are impacted. And often we see the digestive system, the heart, right? Those things tend to go together in development. Where I want to spend some time is talking about our respiratory system and feeding. So our respiratory system is super important. These kids, especially severe kids, tend to wind up with pneumonia on a regular basis, right? Their lungs are not real strong, maybe because they were preterm or related to their genetic disorder. But think about what helps us breathe. Our lungs expand and contract, right? But why do they expand and contract? They expand and contract because our diaphragm moves, our rib cage moves, and these muscles up here in our shoulder and neck move. They allow those lungs to expand and contract. So if my muscles in my core don't work well, I don't breathe well. Jaden breathes very shallow. You saw that little pant, pant, pant that he does. He doesn't tend to breathe very deeply in and out. How do we produce speech? We produce speech on exhaled air. How do I exhale air? My diaphragm has to work, my rib cage has to work, and I have to blow out a bunch of air over my larynx and pharynx, and my mouth and my tongue and all my cheek muscles have to form certain positions in order for certain sounds to come out of my mouth. So if I'm hypotonic, a lot of times I have a very quiet voice, right? Or it's almost like I whisper to talk. Or when I speak, I understand the very first syllable or second word, right? And by the time I get to the end of the sentence, the sound sort of trails off. That's a real sign that their core is weak, right? And that maybe we need to spend some time working on our respiratory system and our breathing and really learning how to expand our chest. And again, our favorite thing to do is work on a therapy ball because that really helps to engage our core and really helps us to produce sound. Feeding is, again, another one of those huge issues for children with hypotonia. And that really ranges from the kids who aspirate and tube feed, right? So that's very different. So they have things like tracheomalacia, laryngomalacia. That's just a softening up, right? So a less than strong enough trachea or larynx in order to be able to get food down safely into our tummy. So those kids have G tubes or JG tubes or NG tubes, right? Lots of tubes in this story. But for the kids who orally feed, a lot of times they don't chew well, right? They go chew, chew, swallow, because chewing is fatiguing, right? Chewing takes energy. A lot of these kids pocket their food like they're going to save it for later, right? That's both a function of, oh, I got tired, and also the fact that I don't know, that under responsiveness. I don't know there's food stuck in my cheeks, right? I don't necessarily remember that. Next to constipation, reflux often comes up as the question I get asked a lot about. And remember, reflux is a function of a sphincter closing off or opening, right? And so if our ligaments are weak and if our muscles are weak, right, those little sphincters don't always do their job. So a lot of our kids have reflux issues, which we have to address. I always carry an extra set of scrubs because I frequently get vomited on. Weight gain. This is a really tricky thing here because there's this aspect of not enough weight and too much weight, right? So with kids with low tone, if they weigh too much, they have to work even harder to move up against gravity. If they don't gain enough weight, they don't have enough calories for energy, or they don't have enough calories to actually start to put on muscle mass. So there's a real balancing act with feeding and nutrition. And a lot of my kids see nutritionists and dietitians, and feeding becomes an integral part of what I have to consider in my therapy regime, because I'm the person who burns calories. And so I've had my nutritionist come to me and say, could we back off of what we're doing in therapy, because we're not gaining any weight, we're losing weight. So sometimes we have to adjust our plans a bit. I know we're running a little bit long. I just want to get through a couple of more slides, and then we'll open it up for questions. So I think in the future, we will probably look at offering some kind of a fine motor webinar for you. So I'm not really going to talk so much about fine motor skills, but rather function. So you'll notice Jaden here likes to push things when he's on his side, because it's hard for him to work on his tummy and it's hard for him to work in sitting. But when he's on his side and he's rolling around on the floor by himself, he can get to the toys he wants and he can make them go. And I know you can't probably see this in this top picture too well, is Louise is actually holding the book up. So when she first started wanting to use her hands, her favorite thing to do was to roll over, stabilize her body on her back, and look at the toys up here. She didn't want to play on her tummy either because that's harder. As she got stronger, she was still sitting really badly in her lower spine. So I moved her toys up so that she had to reach up to get toys. And so if you sit back in your chair now and kind of round your spine, and then you go to reach up for something, you notice how that straightens up your spine and your pelvis. So if I make her play with her toys while she is sitting like this, she's more likely to use those trunk and postural muscles that I want her to use. Okay, so we're going to look at some pictures of some different ideas of things that you can do in your home. Most of these things are pretty inexpensive. They're not paid for by any funding source other than you or your grandparents or your friends. These make great Christmas gifts and things like that. So as we've already talked about, I love therapy balls and yoga balls. They are wonderful. They also make peanut balls. When kids get a little older, and they can do some of their own bouncing and jumping, I love hippity hops. They were around even when I was a child. They're just a therapy ball with a handle. Don't forget about these guys. They are great and they are wonderful tools for your kids. Even once they learn to walk, they always need to work on their core. Low tone children and adults should always own a therapy ball. They should always be constantly working on their core. Actually, I think all people should, but we're talking about hypotonia today. Spinning boards are very easy to make. This is Lazy Susan. That's all a spinning board is a Lazy Susan. So if you have some clever carpenter that can put a Lazy Susan apparatus between two pieces of wood for you, you can make these pretty simply, but they're not super expensive to buy. This one would cost you more money because it's a little fancier. Do not forget the value of scooter boards. If I have a baby who doesn't have a great trunk and doesn't have great leg control, I can still work their upper body. And I can still work on their eye-hand coordination, right? So scooter boards are a great source of fun. We can do obstacle courses, all kinds of things. Swings are something that I think should be mandatory on playgrounds. Not so much anymore. We've taken all the merry-go-rounds, playgrounds, and seesaws and teeter-totters off our playgrounds because, we're worried that they're not safe for children. In the meantime, we've put our kids in containers and they don't move so much anymore. So there's all kinds of swings out there, right? There's adaptive swings, there's infant swings. This is a therapy clinic. And it's got all kinds of swings in it. And if you do private therapy, you probably have seen a gymnasium that looks very much like that. I'm not saying you have to build that in your home, but a tire swing is pretty easy to create in your backyard. And then these are just some simple toys, right? Basically, roadie, there's all kinds of versions of roadie. There's adaptive chairs, little wooden chairs, and these are pretty easy to come by. They're not super expensive. For kids who W-sit, I often use step stools and chairs. Louise has both of these things in her home because she wanted to sit and read books or sit and do fine motor tasks. And I wanted her to be sitting somewhere where she could put her feet flat on the floor so that she would sit upright instead of sitting like rounded. This little disc right here has air in it. And so you can put it on a chair, you can put it on the floor, and basically it's like sitting on a therapy ball, but Louise can sit on this all by herself without us having to really help her do that. Of course, let's not forget rocking horses, rockers, the little bouncy horses. They are so amazing. For people that are older, if you don't want to sit on a therapy ball without a frame, I just wanted you to know that they do make frames for them these days. I've got a therapy ball over here, and I often sit on my therapy ball to work every day because it's just good for me to have good posture as well. The last thing I want to talk about today is children with low tone and loose ligaments are just going to be more prone to injuries, right? They're going to be more prone to hip dislocations, shoulder dislocations, ligament tears. So if you have a kid that is going to functionally be ambulatory at some point in their life, right? Just be aware that they are going to be a little bit more prone to those kinds of injuries. In our next webinar, we are going to talk more about recreational activities, and we're going to talk about more about therapy stuff because we have run out of time today. And we are going to talk about this slide next time. So I am going to move on now to our Q&A time. And I just want to thank again the CACNA1A group and the DEE group for bringing this together. I think this has been a wonderful opportunity for all of us to gather together. And I thank you for your time because I know it's really valuable. So I'm going to let Lisa and Gabby kind of jump in here with any questions you might have.
Okay, well, I will start. I just want to say thank you so much, Theresa. That was just fascinating. And I think all of us wish our kids had a Gigi like you. So, it was really interesting because you talked about how the more we make our kids work, the better they'll get at the skill, which of course is the case for all of us when we're learning anything new. But as a mom, it's also hard to watch your kids struggle because they have such difficult lives and you want to make it easier. So I thought that one important takeaway was the idea of embedding therapy into into your day-to-day activities and natural routines and doing it in small bites. So thank you for that reminder. With regards to some questions, let's see, there were a bunch of questions regarding the therapy ball, and you mentioned how the importance of developing your core and how a weak core affects so many other systems like your respiratory system and breathing. My daughter, I'll just say, gets headaches. And one of the things that we discovered is that her oxygen level is low. And that's because she's not taking deep enough breaths. So it really does impact, the whole body. We had two questions. One was, do you recommend that you change the size of the therapy ball as the children grow and get, older and taller?
Absolutely. So as you saw with Louise and Jaden, right, they're not able to do the ball themselves. Like I couldn't put Louise on a small ball and let that she would work herself. But if your child gets to be 9 or 12 or 15, right, definitely get a ball that's the size that they could sit on themselves. And so I actually had this conversation with one of my little girls who's in 7th grade this week. Is I want her, because she watches TV like 2 hours a night, right? Or they game, right? Whatever they do. And I said, so we're going to get you a therapy ball that's the right size for you so that your hips and knees, right, it's not too short so that you're not sitting down, but so that you're sitting upright, right? We're going to get her the right size. That's critical. And then while she watches TV, her activity is every time a commercial comes on, she's got to bounce on the ball. And I showed her a couple of jiggle exercises that she's got to do. And she's got to sit on the ball for an hour. So even while she's watching the show, if she's sitting still, she's still engaging her core. She's still engaging her legs. She's still engaging her pelvis. She's still sitting upright, right? Because she has a scoliosis and she's in that critical 7th grade, I'm going through my growth spurt. This is when our kids get scoliosis. And so we're trying to do something that she does in her everyday routine, but hold her accountable for it, right? So definitely changing the size of the ball when your child can do it themselves, or even as an adult, getting the right size ball for your height and your body is important.
Okay, great. Thank you. And then Joanne asked, as we were talking.
Sorry, can we just quick ask, is there a way to know which is the right size? Is it based on some sort of measurement that people can follow?
So this is my rule, right? You want your hips slightly higher than your knees. Now, remember, therapy balls give. So sometimes you've got to buy a little bit bigger size because it's going to give a little bit, and depending on how much you inflate it also determines the height of it. So like I'm 5'8", I have a 75 centimeter therapy ball. That's about right for me. But they come in every single size, right? So if you go to a clinic, like the clinic that I worked in as a private clinic, we probably had 7 therapy balls in every size, right? So sometimes a good place to ask is your therapist that you work with, your OT, your PT, right? If they've got access to different size balls, play around with it, bring them, have them bring them to you, or if you go to a clinic, try them out and see. But the best rule of thumb, pelvis slightly higher than knees.
Perfect. Okay, thank you. And then Joanne asked, do you recommend belly scooting for adults to improve the core as well? Because you
Yes.
touched on it for younger children.
Yes, I love belly scooting and crawling. I think even once kids walk, we should still crawl. Most kids do not crawl enough, right? And it's so great for building your core. You don't think about how belly scoot, like get down on the floor and try and belly scoot at our age, right? Like that is so amazing how we work those muscles, right? And reciprocation with each other. Yes, absolutely. No matter how old your kids are. I know I showed you younger kids, but you can translate this up into older kids or adults easily, everything.
Thank you. And in that actually same vein, when we were touching on AFOs and SMOs, you showed us Louise's feet and talked about how, when children have low muscle tone, they collapse their arches in and they lock their knees. So what happens when you have an older child, a young adult, or even an adult? You talked about the SMOs, would those be appropriate? Or what can you do when someone's older and the way they're walking is kind of set,
Right, exactly. So absolutely. I have kids that will have SMOs for their whole life, right? Their whole career. You can sometimes move them into just some arch supports in the shoe, right? I always think less is more sometimes, but I definitely have kids who, their whole life, they're going to have some kind of an arch support. And it really is a balancing act between, I want them to use their muscles. So in therapy, I rarely have my kids in their braces because I'm working on developing their ankle muscles. I'm working on developing that arch. And remember, all babies are flat-footed, right? We don't really develop our mature arch till about the age of 7. So really, we got lots of opportunities with this younger population of kids to really engage their muscles and encourage them to work. One of my favorite things excuse me, to do is like when Louise was cruising side to side, that side to side movement, think about that. That really is that pronation, inversion, eversion, right? That is that movement. So just sidestepping, even if you can already walk, right? Amazing skill set to do, like to help develop ankle movements.
I'm thinking you should stop the share so we can see.
Oh, you know what?
Thank
you. Thank you for saying that.
I just thought about that. Okay, great. And then what about, we have a question about if a child does use AFOs, when would you recommend a child transition to a hinged AFO?
Okay, that is a good ask your personal therapist question. So if I put kids in AFOs, I almost always put them in a hinged AFO from the beginning. Because I know I'm going to want that movement, right? I'm not going to want to lock their ankle completely tight, with very few exceptions, right? There's always an exception to my rule. So if they're doing a lot of work like in gait trainers or walkers, where they're really learning to step, it's really helpful if they have a hinged orthotic. But again, that's a question you really should ask your own personal PT, because different therapists have different ideas in their head about what they want to do, right? And where they're going.
Okay, thank you. There are a few questions focused specifically on hypotonia. So are crossing midline skills an indicator of how severe or mild the hypotonia is? Like,
Okay, not necessarily how severe the hypotonicity is, but how they are able to move. Because remember, in sitting, we develop front to back first, side to side second, and then rotation, right? So crossing midline is a part of that rotation. So I have lots of kids who sit, right? But they can't rotate to save their life. So they can't cross midline. And it's really a matter of teaching them from the beginning how to sit up and use those rotational movements. And so if I get a baby and they're 2 weeks old and they have Down syndrome, they have low muscle tone, from the beginning, we are working on that because I know it's going to be problematic. But it doesn't necessarily indicate how severe their hypotonia is. It's more a function of what muscles they're learning to move and how we work those muscles, right? So if we work a little bit ahead of the curve, right? We know we're going to need these muscles. We know we're going to need the ability to cross midline. Then we know we need to work in rotation. Does that make sense?
Yes, thank you.
Okay.
And then we're really running over. And so I'm trying to, get
No,
through
that's
this
okay.
as quickly as possible, but this question might actually lead into the next topic, which is how do you differentiate hypotonia from ataxia or an ataxic gait, right?
Okay. Yeah. And we are going to talk about that in the next webinar because we are going to talk about ataxia and we're going to talk about kids with hypotonia and ataxia. Because most ataxic kids have underlying hypotonia as a secondary, complicating factor. So can I table that question till the next webinar?
Yes, and that's a great segue into letting everybody know that they should stay tuned for the next one. Which we have a date for it, Gabi?
Yeah.
Yes.
Yeah,
it's it's on February 10th at 11 a.m. Sunitha already put the link in the chat. If people want to follow up, I will share also. We've got this is, I think everybody knows who's been following knows that this is just the first in a 6-part series of webinars that we are doing with CACNA1A Foundation and Theresa. So I'm going to pull up because I've got them here so that people can reference. So we've got the second webinar is February 10th at 11. We just shared. Sorry, it's taking a while to load. On ataxia, hypertonicity, athetosis, and mixed tone. On March 10th, on adaptive equipment and therapies for children with severe developmental delays. And then a few that are yet to be scheduled, but will be in April, May, and June are low-tech solutions for children with complex communication needs, high-tech solutions, and CVI. And so you can register at all of those at this bit.ly here. Yeah, so that's where we'll leave things for now. I would love to continue the conversation, Theresa, too, about working with older kids who are still real low tone. Like I think you can see me sitting here with Elliot, right? And he's 9 and still working on head control, right? So he doesn't have any of that, I love the tools that you shared, but I don't think he could use any of them right now. So what do we do? We've got a bigger kid, and I think, we could probably have a whole other discussion about that. But this was so incredible. There were a lot of comments saying, I learned more in an hour than I've learned in years working with my therapist. So we're so grateful to you for sharing your expertise, giving of your time and your passion here with us today. And we'll see you in a month.
Okay.
And we hope
thank you all so much.
And I just want to reiterate, thank you so much. Thank you everyone for joining. And thank you, Theresa. And we will have this posted on both of our websites so everybody can access it probably in a couple of days.
Yeah.
Thank
the best
you.
place to know is to keep watch on social media because I think we all post it there. So thanks,
Perfect.
everyone.
Bye, everybody.